Hello, everyone. Our topic today is about mouth care and its implications in palliative care and pain medicine. These are the objectives of our presentation today. In palliative care patient, oral cavity represents a true target organ. The mouth plays a fundamental role in many aspects of life: nutrition, hydration, phonation, speech articulation process, relational and communication activities, and emotional, affective, and even sexual relations. Several studies have shown that oral complications and abnormalities of the oral microflora can be found in significant numbers of terminally ill cancer patients, affecting their quality of life. Prevalence. It's been shown that the prevalence of oral signs and symptoms among a group of 70 terminally ill cancer patients, according to Sweeney and Bagg. 97% complained of oral dryness, while 84% complained of oral dryness during the day, and 84% complained of oral dryness at night. Oral soreness was reported by 31%. 66% of the patients had difficulty talking, and 51% reported difficulty eating. Oral mucosal abnormalities were detected in 65% of the patients, most commonly erythema, coated tongue, atrophic glossitis, angular cheilitis, and pseudomembranous candidiasis. Our topic will be divided into fungal, and then we were going to talk about viral infection and their management. Fungal infections. The most common oral infection is oral candidiasis. High levels of candida have been reported among terminally ill patients, with correspondingly high levels of mucosal disease. Debilitated patients, such as those receiving antibiotics, steroids, cytotoxic therapies, are particularly susceptible to oral candidiasis. Other general factors, such as diabetes, predisposing local factors, such as poor denture hygiene, for example, or xerostomia, are also important in the pathogenesis of oral candidiasis. There are at least 150 species of Candida, but only 10 to 15 of them are regarded important pathogens for humans. The most famous one is the Candida albicans. It's one of these Candida species which is found in oral cavity and responsible for most oral Candida infections. The pseudomembranous form, thrush, we call it oral thrush, is a classic clinical feature characterized by creamy white, curd-like patches on the tongue and other mucosal surfaces. The patches can be removed by scraping and leave a raw bleeding and painful surface. And that's why we call it pseudomembranous. Oral thrush. There are also at least 4 other types of candidal infections. One of them is acute atrophic candidiasis. Sometimes we call it antibiotic-related stomatitis. And this is basically a nonspecific atrophy of the tongue associated with burning sensation, dysphagia, and mouth pain. And then we have another type called chronic atrophic candidiasis. Other name for it is denture sore mouth. It's a chronic inflammatory reaction and epithelial thinning underneath the dental plates. Usually these patients, they suffer from dysgeusia. We're going to explain this term later on in the presentation. Angular cheilitis, which is an inflammatory reaction at the corners of the mouth. not due exclusively to Candida, but to mixed infection with Staph aureus, or less frequently beta hemolytic streptococci. Candida leukoplakia, hyperplastic candidiasis. In these lesions are firm adherent plaques involving the cheek, lips, tongue, and symptoms are usually absent. The diagnosis can be made by clinical appearance of the lesion, by scraping, using either potassium hydroxide smear or gram smear to show mass of hyphae, pseudohyphae, and yeast forms. Other simple methods, such as swabs, imprint cultures, or culture of oral rinses. Acute atrophic candidiasis, and this is usually related to patients receiving long-term antibiotic or steroid therapy. Chronic atrophic candidiasis, sometimes we call it denture stomatitis. Angular cheilitis, and candida leukoplakia. Treatment of fungal infections, specific antifungal treatment, either using nystatin or clotrimazole lozenges. The nystatin comes in the form of a suspension, 100,000 units per ml, and patients usually take around 4 to 6 ml every 6 hours, and also comes in other forms. The clotrimazole lozenges are effective and well tolerated in the treatment of oropharyngeal candidiasis forms. Ketoconazole is available in a number of oral and topical forms. The slow therapeutic response, variable absorption, and frequent adverse effects all make it a poor choice for candidates with advanced cancer. So as far as the topical, mainly nystatin and the clotrimazole lozenges. Fluconazole. This is one of the most famous antifungal drugs. It's a triazole with established therapeutic efficacy in candidal infection. Fluconazole 50 to 100 once a day is the most effective treatment of oropharyngeal candidiasis. Daily doses of 100 to 200 are recommended for esophageal candidiasis. Extensive clinical studies have demonstrated fluconazole remarkable efficacy, favorable pharmacokinetics, and reassuring safety profile, all of which have been contributed to its widespread use. The azoles have been implicated in fatal interactions with antihistaminics, okay, in general. So be careful about that. And also, fluconazole, as you know, it inhibits the metabolism of the 3A4, CYP3A4, and thus it has an interaction with methadone and fentanyl, of course. Other agents, itraconazole and ketoconazole, have broader spectrum of action. And these agents also sometimes used for, as an antifungal agents for patients that have candida or albicans or oral thrush. These agents also inhibit the 3A4 and they can cause drug-to-drug interactions. This is the azole nucleus, and the most famous drugs are fluconazole, ketoconazole, and itraconazole. I mean, most of us use the fluconazole as far as I'm concerned. Other fungal infections. So there are emerging species that's coming out, such as Candida glabrata, Candida glabrata, and other ones, Candida cruzi, Para pisolis, and Candida doubly naisis, uh, all these fancy names. These types of Candida are emerging nowadays, and you should have some awareness about it, especially if you're having resistance to the fluconazole or whatever you're giving to the patient. And these are just give you an idea about different candidas. So of course, Candida albicans is the most famous one of these. Okay, but these other candidas are emerging and might be because of the infection and the resistance to the antifungal therapies that you're giving to the patient. In the last years, also there's another drug called caspofungin, and others have shown to have fungicidal activity against most Candida species, including strains that are fluconazole resistant. We'll jump into the viral infection, starting with the herpes simplex virus. Viral infections in the mouth, the most famous one is the herpes simplex type 1, is the commonest cause of viral infection in the oral mucosa. Herpes virus are characterized by the ability to establish and maintain latent infections, which can be reactivated later on for various reasons. Several stimuli include radiotherapy, chemotherapy. All of these can trigger a reactivation of the virus. And usually, the virus manifests as small vesicles, usually appear on the pharyngeal and oral mucosa. These rapidly ulcerating and increase in number, often involving the soft palate, buccal mucosa, tongue, and floor of the mouth. Anorexia, fever, mouth pain, and dysphagia may be present. The disease generally runs its course over 10 to 14 days. Herpes simplex type 1, we have herpes labialis and herpes gingivostomatitis. And of course, it can cause an infection to the cornea, what we call herpetic keratitis, but this is not of our interest in this presentation. So we usually give acyclovir, okay, topical for these viral infections. Acyclovir triphosphate, and it's available in a topical 5% ointment. Also available in an intravenous form and oral form. In the immune-compromised patients, acyclovir is useful as both treatment and suppression of recurrent mucocutaneous herpes simplex lesions. We have another novel drug called pencyclovir that demonstrated efficacy against 1 and 2. Al-Wiley carried out an interesting small prospective study that compared topical applications of honey with acyclovir cream in patients with recurrent episodes of labial and genital herpes simplex. For labial herpes, the mean duration of attacks, occurrence of crust, healing time, and pain duration were significantly lower when treated with honey when compared with acyclovir treatment. HIV infections can also affect the mouth cavity. HIV patients, especially nowadays with these new highly active antiretroviral therapy, the heart, has altered the prevalence of and the incidence of oral mucosal lesions. Although oral candidiasis appear to be the infection more significantly decreased after the introduction of the heart, recent reports show variation in the prevalence of oral mucosal lesions in different population groups. Prevalence of oral mucosal lesions was commonly seen in patients classified by the CDC as C3 category, then CDC A2, A3, and B2 and B3. The heart may predispose to human papillomavirus infection and potentially increase the risk later on to oral squamous cell carcinoma. So the CDC classification, I explained it in the prognostication presentation here, okay? So if you like to return back to this presentation, you will see the CDC classification for HIV. And we're going to show you some pictures for the human papillomavirus and squamous cell carcinoma. So this is the human papillomavirus, and this is the squamous cell carcinoma. So it starts with the human papillomavirus, and it ends with squamous cell carcinoma. Also, HIV can cause hairy leukoplakia and Kaposi sarcomas. Oral candidiasis, hairy leukoplakia, Kaposi, necrotizing ulcerative gingivitis, and linear gingival erythema, necrotizing ulcerative periodontitis, and oral non-Hodgkin lymphoma are strongly associated with HIV infection and may be present in up to 80% of patients with AIDS. These lesions parallel a decline in the number of the CD4 cells and increase in the viral load. Remember when we talked about the prognostication of HIV patients, we mentioned that there are 5 factors. 2 of them are basically the number of the CD4 cells and the viral load. When the CD4 goes down, viral load goes up. This is a poor prognostic sign, because it means that your immune system is malfunctioning, and that's why the virus is replicating. In poor resourced areas like Malawi, they're trying other agents that are cheaper, such as gentian violet, chlorhexidine. Also, they use something called Melaleuca alternifolia, tea tree oil. All of these have been shown to help with oropharyngeal candidiasis, especially in patients that are refractory to fluconazole. Also, thalidomide might be a cheap palliative therapy for those that have Kaposi sarcoma. So we're gonna talk about xerostomia, which basically means dryness of mouth. And these are some of the factors triggering xerostomia: tobacco, dehydration, nerve damage. So I usually ask the patients to stop smoking. Of course, this is pretty difficult for most of the patients, but you have to give them an advice, especially patients having xerostomia and also dysgeusia and all that stuff. And it could be a sign of an underlying condition, such as Sjogren, HIV, Alzheimer, diabetes, and so forth. And it could be side effects of certain medications, such as anticholinergics, for example, antihistaminics, TCAs. Xerostomia is defined as a subjective feeling of oral dryness, and it's one of the five most common symptoms affecting patients with advanced cancer, with a reported prevalence between 30 and 97%. Indeed, despite high prevalence of this distressing symptom, which may contribute to mouth pain and oral infections, there have been relatively little research into this orphan topic in supportive care. There are many general causes of xerostomia, but drug therapies are the most important via a number of different mechanisms, including interference of the nerve supply to the salivary glands or with productive capacity of the salivary glands, such as diuretics and opioids. The indirect effects include imbalance with the normal stimuli to the secretion of saliva. So the commonest cause of xerostomia is medication side effects. The effect of xerostomia in patient symptoms are numerous. The absence of protective effect of the saliva on oral mucosa is a facilitating factor of exogenous bacterial colonization and infections, with the loss of lubrication and which makes swallowing and chewing difficult and painful. I want to tell you, a friend of mine had head and neck cancer, received radical neck dissection, and his only complaint after surgery, was the xerostomia, because literally he couldn't, enjoy any type of food. And I mean, this I can see that it's pretty harsh on anyone. Also, xerostomia is also associated with the taste alteration. So usually you see this xerostomia, dysgeusia type of deal. So usually, in fact, we treat both together in the same setting usually. Causes of xerostomia could be related to the cancer itself, or could be related to dehydration, could be related to the treatment, or related to concurrent disorders. Management of xerostomia. The primary management involves treatment of the underlying cause. Okay. Uh, First of all, you have to discontinue or substitute the regimens that's causing the xerostomia. Patients with ill-fitting dentures can be advised to see their dentist. Relining of dentures can improve their fit and function and help to lessen oral pain and dryness caused by the lack of support of the dentures. Dentate patients should receive preventive or dietary advice as well as treatment of any caries present. One of the most important things you advise these patients is to stop smoking. Common therapy for chronic xerostomia includes the use of salivary substitutes or salivary stimulants. So a drug like pilocarpine is a muscarinic agonist that can help to stimulate the salivary secretion. While you can also use salivary substitute such as mucin-based artificial saliva. And you can use them both together. Extreme caution should be taken in the use of pilocarpine because of the reported side effects of glaucoma, cardiac disturbances, and sweating. Remember, pilocarpine is a parasympathomimetic agent. So it increases your acetylcholine at the nerve endings here. Another simple but very effective way to improve the xerostomia is to use a sugar-free chewing gum. I mean, this could be very useful, pretty cheap, and effective as well. Um, Also, you know, they worked in a drug called amifostine. All right, um, and there's a randomized controlled trial of fractionated radiation with or without amifostine um, before the fraction of the radiation. And they found that amifostine administration was associated with reduced incidence of grade 2 xerostomia over the 2 years follow-up. So these are some of the medication we're using: amifostine, pilocarpine tablets, and then you have the moisturizer like Biotin. This is the one that we used to use in the United States, um, a pretty effective one as well. But there are different brands, okay? So you need to ask about your local pharmacy about which brand is available in your country. Okay, so they also there's been systematic review carried by a task force, you know, to determine, to give the guidelines on the treatment of xerostomia. But in this, with these guidelines, they found that there is an evidence of salivary gland hypofunction, xerostomia, induced by cancer therapies can be prevented or symptoms be minimized with the intensity modulated radiation therapy, amifostine, muscarinic agonist stimulation, oral mucosal lubricants, even acupuncture and submandibular gland transfer. I want to say just a word about acupuncture. Uh, I uh, uh, I think acupuncture can sometimes help these patients. Okay, so there's nothing wrong with sending these patients to an acupuncturist. Let them give it a trial for a few sessions. If it doesn't work, it doesn't work. It's not going to hurt the patient in anything. But it's a simple and it's a non-pharmacologic technique for the treatment of xerostomia. And there are specific acupoints for it. I mean, it's just beyond my presentation today. Okay, I jump another topic here, which is the altered taste sensations. We have the agousia, we have the hypogeusia, and dysgeusia. Agousia is complete loss of taste. Hypogeusia is partial loss of taste, and dysgeusia a distorted sense of taste. So it's been shown that the prevalence of taste alterations in patients receiving chemotherapy was alarmingly high, 69.9%, almost 70%. Patients, in particular, receiving irinotecan courses reported significantly more taste alterations than patients in other treatment groups. Typically, these patients have difficulty in differentiating sour and bitter tastes, which are affected more than salty and sweet tastes. Also, look for zinc deficiency in these folks. So, what are the things that we can use for altered taste sensations? We have the alpha lipoic acid, which is a natural antioxidant, helps with nerve damage, zinc sulfate tablets, and delta 9 tetrahydrocannabinol or THC. All of these agents have been used with success. But don't forget the non-pharmacologic, management, including mouth care, dental hygiene, withdrawal of drugs that can induce the symptoms, given a dietary advice, especially the urea content of the diet can be reduced by eating like white meats and eggs. This masks the bitter taste of food. Uh, as I said, when I manage altered taste sensation, usually there is xerostomia as well. So you might need to use lubricants chewing gum, pilocarpine, all these agents that help with the xerostomia. It's like a package, they come together. So sometimes they don't come together, but just be aware of this. Mouth hygiene is number one, as far as the non-pharmacologic techniques here, both in xerostomia and, dysgeusia. Okay, another topic is the chemotherapy, radiotherapy induced stomatitis. The oral mucosa is frequently damaged during chemotherapy and radiotherapy in patients with cancer, leading to a high incidence of oral and esophageal mucositis. Patients with mucositis often experience considerable pain and comfort. The incidence of oral mucositis ranges from 15 to 40% in patients receiving somatotoxic chemotherapy or radiotherapy, raising up to 80% in patients with head and neck cancer. The WHO has an important scale, which is the oral toxicity scale, which goes from grade 1 to grade 4. Grade 1 is soreness and erythema. Grade 2, erythema and ulcers. Patient can swallow solid food. Grade 3, ulcers with extensive erythema. Patient cannot swallow food. Grade 4, mucositis to the extent that the alimentation is not possible. Other anti-cancer drugs such as alkylating agents, vinca-alkaloids, antimetabolites, and anti-tumor antibiotics are especially liable to cause antibiotics, and it's important to carefully consider the use in patients with advanced cancer. Both chemotherapy and radiotherapy interfere with the cellular mitosis and reduce the regenerative properties of the oral mucosa. A poor nutritional status further interferes with the mucosal regeneration. Oral infections can trigger the mucositis and may lead to systemic infections. If the patient develops both severe mucositis and thrombocytopenia, oral bleeding may occur, and this might be pretty difficult to treat. Direct stomatotoxicity usually is seen 1 week after the start of the chemotherapy or radiotherapy in non-immune compromised patients. Oral lesions usually heal within 2 to 3 weeks. So it's usually 1 week after, and usually non-immune compromised patients, their lesions will heal within 2 to 3 weeks. The most common sites include buccal, labial, soft palate, mucosa, as well as the floor of the mouth and ventral surface of the tongue. In recent years, development of biologically targeted therapies and immune checkpoint inhibitors redefined the treatment of many cancers, but has brought a new spectrum of toxicities, including stomatitis, migratory glossitis, hyperkeratosis, and lichenoid reactions, and osteonecrosis of the jaw. These are some of the treatments of the mucositis here. Management of the chemotherapy, radiotherapy, and stomatitis. There's been a recent panel here that suggested using multi-agent combination of oral care protocols. Potential analgesic effect of topical morphine. So this is something that your pharmacist in the hospital can prepare for you. You can, give the patient a topical morphine, like a morphine mouthwash. Remember the opioid receptors, they are not, apparent in the periphery until there's a tissue damage. And of course, with mucositis, you have oral tissue damage, and thus the opioid receptors start to show up, and thus morphine locally, topically, can do the job in these patients. Another drug that we talked about is amifostine. We talked about it in dysgeusia here. So this is another medication we can use. Also, the old-fashioned topical anesthetics that we used to, the mixed, of like local with Benadryl and Maalox and all that stuff. I mean, you can still use them. I mean, there's nothing wrong with that. It's just that we don't have a lot of evidence behind it. But I mean, most of us use this, mix of cocktails. Palifermin, a drug that, if you remember, we talked about in the diarrhea, presentation here. It's basically a keratinocyte growth factor, a recombinant humanized keratinocyte growth factor has been found to be able to decrease the incidence and duration of mucositis. One of the main side effects of this drug is the development of the, like a layer, white layer on the tongue that's pretty thick and usually, unfortunately, is kind of irreversible. Okay, this is interesting. Using natural honey, for oral mucositis has been shown in two, articles here. One by Biswal et al. And another one from it's an Egyptian study from Ain Shams University, and they found that in fact natural honey could be very helpful in oral mucositis. So this is good news. Osteonecrosis of the jaw. It's also been associated with the use of permethrinate and zoledronic acids, two bisphosphonates that inhibit the bone resorption and thus the bone renewal by suppressing the recruitment and activity of osteoclasts. People at risk include multiple myeloma, cancer metastatic to the bone, who are receiving intravenous bisphosphonates. The risk developing complication appears to increase with time and the use of the medication. The predilection for mandibular, molar, and premolar regions and the infectious conditions that can often precede the onset of osteonecrosis support the recent pathogenesis theories stating that local inflammation and associated pH changes may trigger the release and activation of nitrogen-containing bisphosphonates, ultimately resulting in necrosis. Osteonecrosis of the jaw. Bamias et al. Studied the incidence, characteristics, and the risk factors for development of osteonecrosis of the jaw among 252 patients with advanced cancer. The incidence increased with time to exposure from 1.5% among patients treated for 4 to 12 months to 7.7% those who were treated for 37 to 48 months. The cumulative hazard was significantly higher with zoledronic acid compared with permethrinate alone or permethrinate and zoledronic sequential. In addition, some authors have reported few cases of osteonecrosis of the jaw in patients taking oral doses of alendronate to treat osteoporosis or osteopenia. Comorbid factors such as diabetes, immune suppression, and other use of medications such as chemotherapeutics and steroids. So the bottom line, also some other risk factors include using some of these anti-angiogenic agents such as thalidomide, for example, in patients with multiple myeloma. Local comorbid factors, oral health status, a presence of infection, and history of radiation therapy. So basically, the most you know, you know, the most important agent that's causing this osteonecrosis is zoledronic acid. Number two, it depends on the exposure, how long you've been giving the zoledronic acid. This is another. Also, the patient status. Is he immune compromised or not? Also, the drugs that he's taking, like some of these anti-angiogenic agents, for example. These can predispose, the patients to osteonecrosis, and also other comorbid factors, like presence of infection in the mouth. A survey conducted by the International Myeloma Foundation in more than 12,000 patients receiving intravenous bisphosphonates for the treatment of myeloma or breast cancer showed that 81% of patients with myeloma and 69% of patients with breast cancer who developed osteonecrosis had underlying dental disease, such as infection or had dental extraction, as compared with 33% of the patients who did not develop osteonecrosis. So before you start your bisphosphonates, you need to check on the dental aspect of this patient. The classic clinical features are growing, painful, and unilateral swelling with jaw pain and difficulty in chewing and brushing teeth. The mandible and maxilla, with or without oral antral fistula, are the main areas affected by osteonecrosis. Treatment in patients with receiving oral or intravenous bisphosphonates is principally preventive in nature. Okay? So we don't have really a specific treatment of osteonecrosis, but we do have preventive measures. That's what you need to look at. Okay? In one study by Ruggiero, reported that despite several treatment modalities, minor debridement, major surgical sequestrectomies, partial or complete maxillectomies, and hyperbaric oxygen therapies, no healing occurred in any of the patients treated. So the focus here in osteonecrosis, compared to the other conditions we talked about earlier in the presentation, is that we don't have a specific treatment for it, okay? But we can prevent it from happening. Also, there is no scientific evidence to support the discontinuation of the bisphosphonate therapy will promote the healing of the necrotic osseous tissue in the oral cavity. Antibiotics have been found to be useful for osteonecrosis, including penicillin, amoxicillin, and in the presence of penicillin-related allergies, clindamycin or erythromycin. Chlorhexidine mouthwash or minocycline hydrochloride can also be useful for periodontal pockets. Preventive measures, clinical dental examination. So this is basically the main core of the treatment of osteonecrosis of the jaw. Preventive measures, comprehensive extraoral and intraoral examination, full mouth radiographic series plus panoramic radiograph, evaluation of third molars, removal of abscess and non-restorable teeth, restore periodontal health status, pocket elimination, plaque reduction, caries control, elimination of defective restorations, oral hygiene and self-care education, functional rehabilitation of salvageable dentation, properly fitting dentures, and schedule periodic follow-up visits. Basically, before you start your bisphosphonates, you need to send your patients to the dentist and explain very clearly that you're sending this patient because this patient will be receiving bisphosphonates. At last, we're going to talk about dementia and oral health here. There's a cross-sectional observational studies, carried out in 2 UK hospitals to identify orofacial pain. This study highlights that the dry mouth in patients with advanced disease can have a significant negative impact on the day-to-day ability in these folks with dementia to talk, to eat, to taste, and can interfere with nasal passages, lips, throat, swallowing, and sleep. Orofacial pain in this population is common and may be caused by teeth or their supporting tissues, the muscles, joints, and masticatory system, or non-odontogenic tissues, but can be difficult to detect and is often undertreated. So bottom line, oral health in demented patients can really interfere with the quality of life of these folks. And it's really one of these things that's, goes undetected and undertreated. Key learning points of this presentation: oral disturbances are frequently experienced by patients with advanced cancer. The most common problems of xerostomia, fungal infections, therapy-related mucositis, and taste disturbances. Azoles resistance may become a clinical problem in the treatment of oral fungal infections. Improving dental and oral hygiene, good fluid intake, ice chips, dietary advice, and the mainstay of non-pharmacological prophylaxis and treatment of xerostomia, mucositis, and taste alterations in palliative care patients. Honey can be a cheaper and worldwide available choice for treating herpes simplex lesions and radiation-induced mucositis. In poor resource-limited settings, mouth care for people with AIDS is a basic clinical strategy. Bisphosphonate-related osteonecrosis of the jaw is a challenging problem in palliative setting. Prevention is the treatment here in these situations. Mouth care in advanced dementia elderly people is a challenge for palliative care teams in the next future. Thank you.